Today, we are going to learn about another session, another nursing issues on ostomy care. This will be taken by Mr. Immaraju Swarup. He is an MSc nurse and a palliative care nurse. He is a nurse trainer, and now he is trying to implementing palliative care units in the state of Telangana. And he is working as a nursing superintendent for Kumudini Hospice and under MNJ.
No audio, ma'am.
Well, Shiba, can I start my session now? I hope you have introduced me, but there was a little bit of problem with your audio. We couldn't hear that, but that's fine. Can I go ahead for that? You can just raise your hand to say that because we couldn't hear you.
Can you hear us?
I hope I'm audible. Yeah, now it's clear.
Yeah, okay.
Okay. Shall I go ahead for that?
Yes, you can.
Yeah. Okay, thank you. So, very good afternoon to everyone. I hope first of all, I would like to welcome you all for this sessions. I hope you are having a very good time in palliative care. That was a wonderful experience to every one of us. So I would like to discuss a little bit about the stoma care. Before that, let me just tell my background a little bit about that. I did my nursing, and later on I've been trained in palliative care long time ago. I was been working in the state of Telangana. We already have implemented more than 30 palliative care units. We initiated 30 palliative care units in the state of Telangana. And right now we have been planning to implement the same kind of palliative care units in the state of Andhra Pradesh, which is a neighboring state for the state of Telangana. And even for that, we also have started 2 palliative care units. And the 3rd unit is supposed to be started in next a few days. Most of our nurses have been getting trained here in our palliative care. So I've been working with the different programs. I'm not stuck to one single program in the palliative care. Like we have a pediatric palliative care program. We run a home care as well as an inpatient department, and also the adult palliative care unit as well as the home care setup too. We have a different varieties of programs which are going under. So I've been working in all the programs with a lot of experiences, that's how I'm going on with. Okay, so today in the given topic about the stoma, we are going to learn a little bit about the information about how to manage the patients in palliative care. Yeah, next slide, please. Okay, yeah, go ahead. So a little bit information about the stoma management. Frankly to say, it might look very easier for us to talk about what stoma is all about. It's easier, but somewhere when you think about the patients who really are in need of your support, it makes some sense at that particular point of time. So you may have to think about what exactly your goal of action to be to manage the patient symptoms or whatever it is. So every time when you treat any patients, one thing you have to keep it in your mind. It's all about, do not look into the patient in one single aspect. Like when the patient is worried about the stoma, patient is having the colostomy. Don't ever think about the patient in that particular way, because you have to have a broad mind or broad perspective in managing the symptoms of that patient. Because we know that palliative care is not just about the physical issues. It's not about the patient coming to you, you're caring for the stoma and leaving the patient just like that. But there is something beyond that level in discussing and describing about the psychological and spiritual issues and some personal information also to be shared in that. Yeah, next slide, please. So going on the next slides, we are going to see a lot more about how and what it is exactly all about. So ostomy is nothing but it is an artificial opening, and which means that it is just a mouth kind of opening. There are 2 types of ostomies we see in general. Then one is input ostomy and output ostomy. Input ostomies are something like where it's nothing but the tracheostomy or the gastrostomy, something which goes into that, like jejunostomy, feeding jejunostomy. These are all the input ostomies. And the output ostomies are something, the body fluids or the body feces which comes out through that is nothing but the output ostomy, which are the colostomy, urostomy, and ileostomy. And next slide, please. So moreover, how do we deal with the patient? What is the main role of palliative care? Not what is the role of the palliative care nurses in patients who have undergone or who are supposed to get the colostomy done. So number one is about the teamwork. So it involves all the team members to counsel the patient about how the future is going to be. For example, there is a patient whom we have seen long time ago with the abdominal mass, multiple abdominal masses, which made him more worse, and he also had a fecal vomitings, which was very bad to say. But his performance is good. He is able to do his own works, is active, conscious, coherent, oral intake has been completely blocked just because of this. Only thing is he has to undergo the colostomy. And if there is no good teamwork, and if there is no good counseling, the patient have seen somewhere the other patient who is with the same colostomy, where there was a little bit of protrusion, and the patient was really very bad, and he passed away a few days later. So this was there in the mind of the patient. If one day, if I undergo the same, what is my situation going to be? Will I die just because of this? My quality will get controlled. So I don't want this to happen. So let me just be like that. And he developed a lot of fecal vomitings and he aspirated. One day he died. When there is no good counseling, the way you counsel, it all depends on. When you tell them the disadvantages, that's fine. We may have to tell them that this is what we have to look into. And some other side, you have to see that even though you undergo this planning or the colostomy, but there are good advantages for that. When you go through this, there are a lot of things or a lot of lifestyle changes you make. You live long and very comfortable life. So nobody likes to die just like that or suffer and die. So to make them comfortable, that would be the best choice instead. So that makes sense when you only have a teamwork, because whenever we have these kind of team counselings, we all to sit together and discuss about the patients, and even our housekeeping team come forward and tell us that, sir, this patient have a problem where he really doesn't want that to undergo. Maybe the wound care, not the colostomy, nor anything else. So we get the information from the people who are in the lower range, which means that patients or the family members go and talk to them to the different people in a different way. So you have to think about it. It is not just about the doctor talking to them, nor the counselor going and talking to them. It's important for everybody. Take information from everyone. So that makes some sense in caring the patient or counseling the patient. It is all individualized care. So you can't just tell the patient or the family that one patient had a very good advantages having a colostomy, so you try to undergo. It's not like that. It is all individualized, because some other day he may see the patient who had a colostomy and he passes away. So which doesn't make sense. Never go for that. So when you have a good, clear explanation to the patient and the family, that makes really the family or the patient to understand what exactly this colostomy is. So sometimes we share the pictures to them, tell them that this is how your lifestyle has to be changed. It's all important. Draw a picture and show them, because we see a lot of very poor patients who really doesn't even understand what it is all about. So the main importance of the colostomy, but still somewhere we have to go beyond that level and explain them in a way that people really understood, and try to take the feedback even after your explanation. If you don't take a feedback, they go home and they feel that, okay, this is all that tends to work and we don't want that to happen. And the emotional support, never ever underestimate these kind of emotions of the patient and the family. Do I have to live with the colostomy? Do my stool come out from the bags directly, not from the rectum? So many people doesn't even like that to happen, but some way you have to tell them, bring those approaches to them and convince them and tell them that we are there for you. We are there to support you. Those kind of emotional supports are to be made, and show them where exactly the site of marking has to be. Okay, this is where the opening is going to be. And these kind of bags have been placed. So it's all very important for you to talk about the pre-operative counseling and prepare the patient and family for the openings. Yeah, next slide, please. Thank you. So the common problems in palliative care. So for example, there is a patient who has undergone the colostomy a few months ago, and he had a little bit of leakage of stool, and he's not putting the bags properly, and a lot of foul smell, a lot of excoriation. The patient comes to you, you have to bring it into a broad mind where you have to think about all his other problems. There are few physical problems where I have mentioned in here. That is nothing but the excoriation of the skin, which is the most common problem the patients experience with the colostomy. But somewhere I was surprised when I've been to the other countries where I saw few patients with the colostomy, and they have a very good background or the education or information about what exactly the colostomy is, how to prevent these common problems. And I haven't even seen a patient with the excoriation even, but that's a good sign to say. So this all happens from the stage 1, where if you start having a very good counseling, tell them that these problems may arise. We also have a solution for that. Don't ever go for such situations where your skin get excoriated. So that's the first problem, like excoriation of the skin. Number 2 is a foul smell. Bad smell is almost common because the stool in a semi-solid state, it just comes out and expels out, and sometimes it may leak and creates more of a foul smell. Number 3, fistulas. Not so common. Very rarely you see patients getting these kind of fistulas. There will be the abdominal fistulas where the stool will be leaked all over the abdomen. Wherever the opening is, the intestines just open up and throw all the feces out, and it gets leaked in, because sometimes even bags might not be the right option even when there is a multiple fistulas happening there. And stitches around the stoma is also has to be observed for. The bleeding. Sometimes even there would be bleeding even from the colostomy, not the surroundings. So consider it while you are trying to take the assessment. It's very important for every one of us to remember one thing, that is, when you go out to see the patient, have a broad mind in asking a questions like physical, psychosocial, spirituality. And then when you have a good assessment, it's easy for you to manage those symptoms well. And it doesn't end with the controlling or managing the symptoms. It also continues even after that as a follow-up case. So keep that things into mind when you start dealing with the patients. And next thing is the psychological problems. Many times we see there are people who doesn't even talk about their social or spiritual issues or the psychosocial aspect even. So when you grab those information, it's easy for you to manage even the physical problems. Sometimes I heard one patient saying that I'm not worried about me having this colostomy, but my wife is not letting me to allow onto the bed. So I'm not able to be close to her. She's not so comfortable with me. Even though if I die, I don't mind. But somebody like, his loved wife maybe, she's not allowing him to come closer or talk to him or touch him just because of the feces coming out from the colostomy, which is making him more bothered about. So these things might not come directly when you talk to them. These things might come only when you have a very good relation with the patient. Start talking to them, ask more about these psychosocial issues and the family issues, or the relation between the wife and the husband, or the children and the father, whoever it is. When you start talking about that, you try to gather a lot of information. So it means that you are not just acting like a nurse, you are acting as a whole, because hospice or the home care, not the inpatient, not the outpatient. The palliative care is all about run by the nurses, that's all. Because most probably the whole target is about the nurses. Whatever the nurses grab the information from, it all deals with that. That's all. Yeah, next slide, please. Okay. So in your assessment of stoma, as I told you before, the assessment plays a major role. When you see such patients, number 1, look for the color of the stoma. How does the color of the stoma look like? Number 2, is there any specific bleeding observed, or is there any stomal edema around, or the herniation, or how the prolapse is? Is it below 1.5 nor crossed or exceeded 3.5 centimeters? Sometimes it would be an ileostomy, and or is it a prolapsed opening, or is it retracted or stenosis? Look also for the peristomial skin condition. Next slide, please. Okay, so here you have an assessment. When you observe some kind of symptoms or the problems in the patient side, okay, you have a care plan. Only thing is, when you observe for any kind of such problems you have to have a care plan. This care plan goes on, doesn't stop just with you in your own shift. It continues with the next shift taking nurse, nor even the night duty nurse, nor tomorrow. So it would be a care plan for a next whole week of what exactly the nurse, as a nurse, I should do. What are you aiming for? What is your goal of action for this patient? My aim is to control the excoriation. If you find there is an excoriation in the site, okay, that's fine. Okay, coming back to the point. So if there is any bleeding, okay, you have a different action of plan for bleeding. So when you have such care plans available or ready for you or around you, that makes some sense, not just for you, also for the nurses to manage it. So if you find the skincare is very poor, the skin condition is very bad, then these are the steps what you have to go through. Like wash with the soap and water. Just these are all the home-based measures what you have to do. Number 2, clean and dry. The bag or the surroundings of the colostomy should be clean every day and it should be dry. So do not apply any kind of moistures, nor it should not be moist all the time, because excess moisture may lead to more damages to the skin, which leads to an excoriation again. So these are the things what the family has to be taught about. So many times I see patients come with a very vague information that, okay, they have put the colostomy, so I have to change the bags every day. Once the bag is full, I have to just throw it out and take another bag and put it on. This is not a machine, right? Okay, every time you have to think it as a human being. So you should keep it in mind that, okay, it's important for you to deal not just with the physical issues. Yeah. So when you talk about that, it's important for every one of us to even think about their educational status. So do you think all the information what you are sharing will be addressed or accepted by the patient family? Not at all. There is a little bit information itself can change a lot of such worst case scenarios. Little bit of information, that's all. So even how to change the bag, when to change the bag, it is also very, very important. Like empty the bag when it is 3/4 full. When that is when it is filled approximately 3/4 of the bag, then you have to just take it out, because overloaded or heavy weight, it may just get disconnected anytime. So it's important for them to understand that once the bag is filled, at least more than a half, you have to just open it and clean it off. Use soft cotton material to clean the surroundings, because when you use a hard material around, because of the more moisture, because of the skin getting damaged very soon, when there is a hard cloth rubbed around the area, you see a lot of excoriation. So it's very important for you to tell them that very gently, use a little cotton material and clean the surroundings, make it dry, leave it open. Never try to avoid any kind of powders or creams unless there is a need. Like you can add some kind of antifungal powders like fluconazole, clotrimazole for a period of time, maybe for 3 to 5 days, to control that kind of fungal infections around. That's all. And next comes to the skin excoriation. So if you find the skin excoriation around the colostomy, what is your action going to be? So that is nothing but the Carrea powder. I'm going to show that in the next slide. And Carrea powder and mixed with the egg white application. We'll talk about that in the next slide. Next slide, please. Okay, we'll talk about that. And meanwhile, I would like to show you some kind of bags what we use in our state right now. So these are the sticky bags, and 17501 is a code number for that. So based on that, the patients will be issued on. So they get at least 2 to 3 bags per month. For a whole month, they just get only a very less number of bags. These are all been given for the free of cost from our government hospital. Even though we work with a private organization, but we have been collaborated with one of the regional cancer center, where we get a lot of patients with the colostomy and a lot of pain, and we provide free of cost like morphine, fentanyl, methadone, a lot of such things. So as the same, we also have the bags available given for the free of cost. So have a look at the bag. On the right side of the screen, you can find there are some little bit of measurements or some circumferences you can see. So it is nothing but the numbering there. So only thing is just look at the colostomy size. So on an average, you just have to take a piece of paper, cut it around, and just place it on the picture what you see on the right side. So you'll get an estimation of how depth or level you have to cut the circle of the colostomy bag. So this is just on the other side of the opening. On the other side, it is just an what to say, it is not transparent, a hard material, a polythene sheet placed on the other side. And you just have to cut it open and stick it over the right hand side, over the top of this picture, right end of the picture. You can see a red mark there where you just have to peel it up, and you see the sticker there, you just have to fix it directly. But on the left side, you can see lower end, there is a locking system, a very good locking system, I can say, because only there it just have 3 layers there, and you just have to strap it well. So once you strap it well, the stool which is collected, sometimes it would be liquid or semi-solid, it will not get leaked through that. And one good advantage I see from this bag is the stool which is collected into that is not visible. It is not transparent. Somewhere it has been mixed with the stool color even. So it is not completely visible. And there are 2 layers of sheets over that. One directly have a contact to the skin, and the other one is forms or binds a layer over that. So this is a good bag to say, and it sticks well. It has a very good sticking layers over the bottom end of this. And on the other side, it is a little bit expensive. I can't say that it is expensive, but somewhere for patients who really doesn't have money to eat, or patients who doesn't have money to buy those, are really a problem. So buying these bags, or each bag may cost around some 250 to 300 rupees per month. They may approximately need 3 to 4 bags. Nor some patients who have their diarrhea, frequent usage of the bags, which may also disturb their financial status again, they have to go and purchase these bags again. So there are little bit of advantages and disadvantages. Many times I see people doesn't go into the best part. What would be the best product? They only think about which bags are more useful for me, and for today, which one would be comfortable for me. That's how they just look into. Next slide, please. Okay, this is the one on the right end of the screen. These are the transparent bags, which really doesn't have a very good locking system, and it costs around some 80 rupees per piece. So it's easier, but it doesn't have a very good sticking pattern here. So these are used only for the very temporary, like when you're traveling or you don't have the bags available, you can just use it from morning to evening, and you just have to discard it. But it doesn't look good even. You know, the stool collected into that is more visible, and many people doesn't like to use that, so they just leave it open. On the left hand of the screen, you have a bag which are from the Ostomy India. It's a nice bag to say. It also have a belt system, and it is not a sticky system. You know, somewhere it doesn't need to stick to the body, because sticking more frequently may leads to a lot of excoriation. So that's the reason why many patients develop excoriation around the skin. It is all because of sticking more frequently to that side, and there is no proper ventilation to the surface, and more of pressure again, which is nothing but the pressure source may develop, which is nothing but an excoriation. So these are the bags on the other side, which are more flexibly used in many of our patients. Very cheaper, and this is a lock. It doesn't have a locking system, but only thing is you just have to tie up with a thread or a clip or a band, whatever it is, because it was not given for that, because to live long. Because these bags, once you purchase it, this can be used for more than 4 to 6 months for a period of time. You need not purchase again and again, and it is not expensive too. 2 bags and one belt may cost around some 150 rupees, because these are the products which are skin friendly. It doesn't damage the skin, and it doesn't have the stickiness even to encourage that kind of skin excoriation. You just have to fix it there and lock it well over the lower end. Once the stool is collected, you have to remove the belt, and the bag can be washed out well, made it dry. So once it is dry, you can reuse it till the time you can use the other bag. I mean, 2 bags you need to have with one belt. So that makes some sense and very cheaper, and easily used for the patients, because at least for 4 months, the patient would not spend on this colostomy bags, because many of our patients, it is not a whole, like patients are not completely dependable on only the colostomy. They even have multiple other problems, like incontinence of urine. They need to buy the diapers, they need to buy the medications, they need to go for the review. There are a lot of other things beyond this. So think of a patient in a different ratio or scenario, and that will make your work more easier. Next slide, please. Yeah, this is another bag which have a very good clamping system, and it is a little bit of expensive, and it is not transparent. So it is a skin friendly, and it is not transparent, but it is a little bit expensive. So which is more cheaper and easily available for the patient we are trying to. Next slide, please. I just wanted to show those pictures to you, that's all. So this is how the opening looks like. So more of protrusion you can see. When you observe, next slide, let us go to the next slide. Have a look at this. As I told before,
Sir?
yeah, am I audible?
Yes, now, sir. We lost for 2 seconds.
Yeah, I
Please
got
go
a
on.
call. I'm sorry about it. Yeah.
Okay, okay.
So when you just observe that, the picture here, the stoma looks cherry red in color. So just think about my assessment. The skin is also a little bit red, the surroundings, and there is a lot of protrusion even. How about the distended abdomen? I go back and look into what the diagnosis is all about. Do you think the patient is in the end of life? Now the patient is able to do or perform his own works? That's fine then. If the patient is able to perform his own works on his own, you need not worry about that. Only thing is, you have to talk more about how to change your lifestyle. Once you start changing your lifestyle, just a minute, please. Just 1 minute. I'm sorry. Yeah, there was a little bit disturbances. Like I'm on a home care. My nurse was coming and asking for some help. Yeah. Okay. So when you look into that, I even look at the patient's work. I even talk to the patient to ask one single question about, okay, you have a colostomy, you have an excoriation, you have a lot of things there. But what exactly is bothering you right now? Is this bothering you in a different way? Like, I'm more worried about my kids or my family. Will this spread to the others? There are a lot of such things making the patient think about. So if that is how the situation, you have to really deal with the patient's condition. So you have to talk it in a different way, and also think about, have a plan of action for the excoriation. When there is an excoriation, okay, there is another plan. I'll talk about that later on in the next slide. Next slide, please. Okay, so there are few nursing issues which are happening in that. Number one is about the irregular bowel action. Irregular bowel action, which means that sometimes when the patient is on colostomy, they don't pass the stool well. So what would be the plan of action for that? Okay, how to manage the bowels in a regular intervals? Okay, that is number one. Number two is constipation. How to manage the constipation? If the patient has been constipated, so what kind of plans do you think the patient would really need in? Sometimes there will be the intestinal obstructions. Many times there are such patients where they even need, just 1 minute, please. Okay, so the patients sometimes may develop more of intestinal obstructions. When there are multiple intestinal obstructions, sometimes laxatives might help the patient, or sometimes the enema can also even help that, because many of our patients, enema is also been given through that way. which gives them a little bit of comfort for the patients. So on the other side, sometimes the patients may develop diarrhea even. So if there is a developed diarrhea, which means that because increase the intake of fluids and hospitalize as early as possible, there will be the multiple problems for the patients for the reason for the diarrhea. So if that is a single reason, that's fine. If that is any kind of um, problem like intestinal infections or more of motility is increased, if that is making them or bothering more, then you have to go for it, go for such investigations. Unless it is not happening, that's fine, then it doesn't bother the patient. So but sometimes even flatulence is also one of a problem where the patients need to be looked into. So many such nursing issues can be managed even at home, nor sometimes it also can be managed even in the hospital setup. Uh, Nor even many of our nurses try to teach the family as early as possible to the family members about the, we call it as a crisis plan, nor the anticipatory plan. Sometimes there are few things which may happen in an emergency, not sometimes there are few things which you need to look into. So that depends on patient, because it is all individualized, so you need not worry about that. Next slide, please. Yeah, so as we have seen some kind of excoriations even before, and this is one of kind of excoriation. As I told you, when you see little bit of excoriation, first step is, only thing you need is just leave it open. Do not fix the bags again and again when there is an excoriation, because more of excoriation, when you stick more bags again, it leads to more worst scenario. So to prevent that, leave it open. So leave it under the fresh air, have a good ventilation to that, let the skin becomes dry, apply some moistures, so skin gets its tone back again. So that would be more helpful. If there is a worst excoriation, only thing is, there is a powder named gum acacia, a Caraya powder. Can you hear me? I hope I am.
Yes,
Okay.
sir.
So there is
Please.
a powder named Caraya powder. Only thing is, take a small bowl, little bit of Caraya powder, poured directly into the bowl with an egg white, mix it together. So stir it well. So there should be no crystals forming into that, and mix it well. So you see a little bit of paste form, the powder and the egg white together, which is a sticky part of that. When these two comes together, it forms like a jelly form, and these paste can be applied over the excoriation site and just leave it open. Nor if the patient need to, because this is a colostomy, the patient need to put on the bags. If not, there will be more of leakage of stool, and the patient feels very uncomfortable with that. If that is how, only thing is just apply some paste around, leave it open for 2 minutes, take a polythene cover, cut it in a circular manner for the colostomy to be open, and just paste it over that. And it gets stick in next 2 to 3 minutes. And then put the colostomy bag over that. Here we have 3 layers. One is the skin, excoriated skin area. Over that, there is an egg and caraya powder together, a mixture together. And the third thing is, there is a polythene sheet above that with an opening for the colostomy to stick to the bag. And over that, the colostomy bag is fixed in. So this helps to remain for next 3 days. You need not open the whole pattern again for next 3 days. You just have to leave it like that. And the third day, you just have to apply some little bit of water over there, sprinkle little bit of water, and the sticky part comes down to the normal stage again, maybe after some 5 minutes, and it's easy for you to clean that area. So you can observe that the excoriation will come down. How am I telling that is, this is an Ayurvedic preparation. Karaya powder is nothing but a product or the extract of the plant named gum acacia, which helps in healing, and the egg white also helps in cleaning, also finds a good layer in preventing the pressure over that particular area. Yeah, next slide, please. Okay, this is a product named Karaya powder from the company of Ostomates India. We have a lot of products from that company, which are very cheaper and more useful for the patient compared to the other materials what we use. Next slide, please. Okay, So this is about the colonic irrigation. So till now we spoke about the fixing the bags to that area. We also have discussed about the sticky bags, and there are few reusable bags. And apart from that, this is a colonic irrigation. Comparatively, this is the much better, more comfortable colonic irrigation setup there. We'll talk about that. So this colonic irrigation establishes a regular bowel habit. Only thing is, when the patient undergoes this kind of colonic irrigation, that really helps the patient in continuing this bowel habits. Number two, clean the colon of the gases and mucus and the feces which are being collected through this. So it helps in preventing the skin exudation. It means that you need not stick the bag directly to that. Only thing is you have to just clean it up and leave it open. You do not put the bag again. So that's a good advantage for that. So it removes all the food ingested by the patient. And once the habit is formed, it has to be done on an alternate day basis. It need not to be done every day once it is used to. Yeah, next slide, please. Okay, this irrigation need to be continued lifelong, because if it is a temporary colostomy, there are multiple other sticky bags or the reusable bags available to prevent that excoriation or make the patient comfortable. If it is a permanent colostomy, the days what the patient lives in need to get managed with the colostomy bags nor the irrigation. So irrigation would be more comfortable for the long-term use of such patients. So generally, once you start it, the habit formation, it need to get used to. So I will talk about that irrigation in the next slide, next few slides. So it forms a habit only once you continue it for next 21 days. Use it regularly in a fixed time. Do not skip the time, because bowels has to get used to that the procedure. So habit formation only after 21 days. Irrigate daily at a fixed time. So just keep those things in mind. The next slide, please. Okay, this is how the irrigation set looks like. See, there are two things in that, and there is also a belt. I'll talk about that later. So there is a bag which is placed over the top end, and on the other side there is a regulator, and the lower end there is a funnel. So funnel goes directly enters into the colostomy site. So it enters into the colostomy, and the water is released through the regulator, and the whole water gets into the colon or the intestine. Once it enters into the intestine, it comes out. We'll talk about that in the next slide. Next slide, please. So this is how, see, the man sitting over there with the stand hanging with 1.5 liter of water, a mineral water into that, and it has a tubing with the lower end. There is a loop funnel where it enters directly into the colostomy. So before applying that, there is a pan style reusable washable drain bag. We call it as a drain bag. So those bag have opening from the top end and the lower end. So over the top end, like earlier we have seen the colostomy bags, there is an opening. So from the top end, there is an opening where you can just directly introduce the funnel, the lower end of the so water loaded bag. The lower end of the funnel is placed directly into that. First, you have to fix the drain bag and then this funnel bag. So once you fix it directly, you have to release the water in. The water enters into that, wait for some time, and then the funnel can be removed. You don't need it again. Wait for a while, and the drain bag will be collected with all the water or the mixture of the stool, liquid, or a little bit of solid feces will also come out of it. So let us go to the next slide with a little bit of information in this. Okay, the solutions used sometimes are the plain water. The patients normally go for the good, when like drinking water, the mineral water we can say. Sometimes even the normal saline can also be used. Preferably not sometimes the soap water, even through the enema it also can be given. Next slide, please. Okay, so there are a little bit of information which need to be shared. So start irrigation 3 months after the surgery, not just after the surgery, because the bowels even has to get used to that condition. So sometimes, that to say that bowels really plays a major role in getting adjusted to the situations. So it takes a little bit of time. That means for 3 months, you need not go for this colostomy irrigation. you have to wait for that. So do not irrigate if there is diarrhea. If you find that the patient is having diarrhea, just have a look at that and don't do this colonic irrigation. Do not irrigate through the ileostomy because the volume is high and you are going to put more of load on that. So don't irrigate more than once daily. So once in a day at a fixed time, that will be more preferable, because once you start doing it and it is continued, you need not worry about the other timings. Like, the site where the colostomy is, it doesn't have any control like sphincter muscle over the anus. So only thing is you have to do, you have to wait for that. Once the patients get used to that bowels, they just have to put a pad or a soft cotton cloth on the colostomy for safety. That's all. Because once the bowels are empty, it takes approximately 12 to 18 hours, large bowels, to collect the stool. Once it is get used to that, tomorrow morning at the same time, the patient's stool will get collected. So it makes a lot more easier instead you going for the enemas or suppositories again. So just have to think about that. So use 1 to 1.5 liters of water from the bag which is filled in, and this water will be entered directly into the intestine. So lubricate the funnel before introducing. Do not forcefully introduce the funnel directly. You just have to be little bit careful and lubricate it well. So do not use force to introduce the funnel into this. Clamp and remove the tube from stoma after running the fluid. Once the fluid is run into the large intestine, this funnel can be removed and wait for the drain bag to get to collect the stool from there. Okay, so wait for the return flow for 30 to 40 minutes. Approximately may take 30 to 40 minutes for the stool to irrigate. Yeah, next slide, please. Okay, so you have to seek for help. Not the family has to be taught about when to call for help. Number one, when there is a continuous blood oozing from the site, which means that there would be some kind of intestinal mass which is bleeding, or there is a little bit of damage in that, nor there are multiple other reasons where the patients may have blood oozing from the intestine. So when there is a prolapse or more of retraction and hernia, just have a look at that, and it has to be brought out to the doctor's notice. Sometimes when there is a colicky pain lasting more than 6 hours, have to think about that. It's important for us to think about the reasons for the pain. Why do you think the patient is suffering in pain? What would be the cause of the pain? So when there is diarrhea and dehydration, constipation, and abdominal distension, you need to seek for help. And ileostomy, which is not functioning for more than 24 hours, you just have to go for the hospital for further evaluation of the reason for the blockage, and look for any kind of periostomial skin problems. Next slide, please. So supportive care, like I told you before, when there is an aspect which is bothering the patient, don't just look into that aspect. Look into the whole of the patient, like physical, social, and spiritual other issues, and you'll get a lot of information. So this is a holistic approach on the patient side. Next slide, please. There are a few phases of ostomy. Number one is a shock or panic when somebody come to know that his lifestyle has to be changed. Everyone are in a different way, but I am in a different manner. So they will be in a depression or worry and anxious about their future. So I have to live my rest of life in the same way. If that is bothering the patient more, you have to think about that and take such steps in managing that. It's nothing but only thing is you can be there to support them, because no other people come forward to talk to them or tell them about that. But it's important for every one of us to understand and show some kind of empathy to the patient and family. So defense, retreat, or denial. Sometimes people doesn't accept that I don't want this life to. Why am I suffering at life? So it's important for you to have an active listening and just console the patient, acknowledge. So you have to acknowledge the patient, and adaptation and resolution in such situations is more important. Next slide, please. Okay, so in the physical symptoms, like earlier we have seen, skincare. So teach the family members about how to take care of the patient at home, because these patients are not going to stay back with us for the rest of their life. They go back and live a different life there. So in their own given life, what are the things? Think about how the house of the patient is, how the family members are, who are the main role in helping the patient at home, who are financially supporting them. So when you have a broad mind like this, that makes your work more easier. Teach the family, give them a brochures, information sheet uh, about how to take care of the skin, and managing how to manage the leakages, bad odor, gas or pain, sometimes even fatigue even. So how to change the clothes more frequently. So sometimes more of contamination just happens with the unchanged clothes. Yeah, even sleep disturbances. They worry that I couldn't turn to the other side because the bag may get destroyed or get open. So there will be like a leakage again. So to prevent that, they'll just try to sleep only in one single position. They can lie down in the other sides, but still it should be more comfortable for the patient. And how about the diet and the exercises? The nutrition and exercises also plays a major role in that. So it also has to be considered. And the lifestyle changes has to be modified, but it also has to be told to the family members. Next slide, please. Some kind of psychological problems like the depression, anxiety. They feel uncertainty and privacy. They don't like such things happening in the public places. People doesn't even like to go out of homes because people may look them in a different manner, and that is not that doesn't make the patient more comfortable. So fear of recurrence, so which means that my disease has come back, I may have to suffer my rest of the life. So negative thinking about, there are many hospitals around me, but none of them are helping me. There are a lot of my family members, but even though I'm helpless. So such kind of situations also has to be addressed. Isolation, and sometimes they isolate from the family or the others' friends. Next slide, please. Yeah. So preparation for the emergencies. Sometimes such kind of anticipatory plans really help them. So social issues like how to deal with any kind of emergencies. If they want to travel, if they want to go for the work, or any kind of public situations, how to deal with such conditions. So stigma also has to be discussed about intimacy and sexuality, caregiver and patient and partners relationship, and financial management. When you have a broad aspects in your mind, that will be more helpful for you in managing such situations. Next slide, please. The spirituality, acknowledging is a main concern, and searching and applying for the meaning and the faith. Yeah. Next slide. So it all happens like earlier we discussed. It's a multidisciplinary approach. So everybody have to come together in doing that. It is not just a nurse role in doing the colostomy care and just leaving the patient alone. You have to touch all the other aspects of life. So which means that the real palliative care is all about. So there are many people involved in that. Even the volunteers role might not be doing the procedures, but somewhere they can just sit with the patient and have a chat with the patient, share those informations. Even the volunteers from our side also have been trained of how and what to talk about. Yeah. So this is another type of ostomy. It's about the tracheostomy. So you can just have a look at the inner cannula and the outer cannula, and there is a locking system above. And this is how the cannula is being placed in. So this is why I'm talking about this is more of excoriation may even happen with the metal plates placed around. So when there is a metal plate, more contact with the skin, patient may develop a lot of excoriation. If there is no good health education to the family, slowly what they do is they they damage more, and they are prone for more infections, because day one after the surgery the patient would be comfortable for first week or more than that, and later on the family may touch that part again and again with the bare hands, or even the patient himself might touch that. So which means you are introducing more of infections into this. Slowly, the patient may develop a cough and sneezing, more of fever, thick sputum coming out. So, to prevent all this kind of even excoriation, to prevent that, more of health education is more important to them. So, tell them that how to deal with that. Next slide, please. A little bit of information is mentioned in there. Okay. So, tracheostomy care. Number one, fine threading around the tracheostomy. So it should not be more tighter, or it should not be more loose. It may get disconnected. It should be soft and smoother and easier for that. And number two, have a good hygiene, which means that unless I have a hand wash, I'm not going to touch that area. And even after touching that area, I'm come out with washing the hands. So people doesn't do that, but we may have to encourage them. We may have to teach them about how to take care of that. So care of the inner cannula, care of excoriation, like the same kind of curry powder and egg white mixture can be applied over the surroundings, and that will be more helpful. And patients and family education, which plays a major role, because we are not the people treating them all the day, all the rest of the patient's life. It's important for the family members to understand, and or the family members to understand and how to deal with such situations, and also look for the emergency. Something goes wrong or situations become worse, try to take the local resources. And next point is securing the site. So how to secure the site? It should be covered well. No dust should enter into that, and make it open, uh, make it more comfortable for the patient instead. Yeah, next slide, please. So the take-home message is the acceptance of the stoma, social interaction, self-care efficacy, and getting adjusted to the situations like social interactions and interpersonal relationship. Yeah. Thank you. Hope we'll take the
Thank
question.
you. Yeah, thank you, Swarup, for the wonderful session. Anybody have any doubts regarding this feature? Please ask him. So one question, what should be used to lubricate the funnel? We can use silicone jelly. Any other questions? Uh, okay. So I hope nobody's have any doubts regarding the sessions. We can move on to the patient story. Swarup, can we?
Yeah, yes, please. Yes, please.
Okay.
So maybe after the case presentation, they may have a lot of questions. I
Yes,
guess.
yes. Simi, over to you. Simi? Can you hear us?
Hello, Sumi ma'am.
Yes.
A little bit louder. I think you can turn off your video if you are traveling, and you can continue with the presentation.
Simi, you're not audible. Can you hear us?
Yeah, ma'am.
Yeah. You can
Shall I
start.
start?
Yes, you can start.
No. Good afternoon. My name is Senior Rachel Thomas. Recently working as an assistant coach in College of Nursing. Actually, for taking the case, it is so, I'm much interested in this palliative care. And this is in fact one of my family members. So will be presenting the case. So the patient it is for male patient. Diagnosis was right hemiplegia, left MCA infarct, left ICA occlusion, Along with that, the comorbidity of hypertrophic cardiomyopathy and intermittent atrial fibrillation. Presenting complaint, patient found unconscious at home around 6:30 p.m. in the evening with episodes of seizure. While bringing to the emergency department, he was drowsy and had right hemiplegia. History of illness. Patient was admitted with unresponsiveness at home on the day of admission. Patient was apparently normal before and suddenly found fell down on the floor with attacks of and facial irritation. He was opening eyes and falling, unable to speak anything. On admission to emergency department, he was drowsy, had right hemiplegia, grade 0. He is a known case of hypertrophic cardiomyopathy with intermittent AF for many years and had irregular follow-up. On examination, patient was drowsy, GCS was 4 out of 15, NFSS score was 22, pupils were normal in size, right-sided hemiplegia, right upper limb and lower limb grade 0, BP was 150 by 90 mmHg on emergency room. Temperature was normal, pulse was 78 beats per minute, and respiration was 20 breaths per minute. Treatment and physical investigation. CT brain showed acute left MC middle circulatory tertiary infarct. Mass effect evidenced by effacement of adjacent sulci, left lateral ventricle and minimal midline shift to right. MRI brain with MRI showed large fresh impact in left MCA territory involving left capsuloganglionic region and left frontoparietal lobe. Few small discrete chronic ischemic signals in bilateral cerebral hemispheres were found. MRI reveals near complete non-opacification of centrus and cavernous segment of left IC and their left MCA. Sputum culture showed Klebsiella species and echo showed concentric LVH, no regional wall motion abnormality, good LV function, mild MR, and dilated LA. Treatment, patient was intubated and was put on ventilator in view of poor GCS, thrombolized immediately with IV tissue plasminogen activator, and further managed by antiplatelets, statins, and other supportive measures. During his stay, patient had aspiration pneumonia. It was managed with antibiotics. Patient was weaned off on the fifth day and was shifted to his room. Physiotherapy and sleep therapy started. On discharge, patient had right hemiplegia, grade 0. He was aphasic, diminished gas reflex, bowel and bladder incontinence. On examination, I think we already the psychosocial aspect, he was very active, extrovert, and had good social relations before. He was the head of the family, and that during the after the phase, he looked depressed and irritated, crying often, unable to communicate his feelings and pain. Wife is the caretaker who had diabetes and arthritis. He had poor attention, financial crisis to the family, worried about daughter's marriage, worried about functional limitations and disabilities, was embraced with a police catheter and the use of diapers. Medication. On discharge, he was prescribed with epoxyrin 75 mg, 010, Tapchonac 40 mg once daily, Codron 200 mg BD, Digoxin 0.25 mg OD, Eptoin 100 mg BD, Dilsum 30 mg BD, Modalet 100 mg OD, Dabigo 150 mg BD, Atifib 200 ml second hourly, and total intake was limited to 2 liters per day. Main concern, He was unable to express his feelings and concerns because of the aphasia, and there was sudden social isolation and neglect. His dependent role in the family, primary caregiver, is also not that healthy. Financial burden, quality of life was decreased. Access to physiotherapy and speech therapy at home. Summary. Patient feels lonely and isolated, is not ready to meet his friends, easily gets annoyed. Family members are unable to understand his concerns because of aphasia, need assistance in self-care. Discussion forum. How we can give palliative care to this patient? What are the problems faced by his family? How we can support them, enhance their quality of life? Thank you.
Thank you, Simi, for the wonderful presentation. Anybody need any more clarification regarding this patient story? Please ask her. Otherwise, we can move on to the discussion points. Anybody need any more clarification? Anything? I think nobody need any clarification regarding this patient story. The presentation is clear to everyone. So we can move on to the discussion points. So how we can provide palliative care for these patients? So we all learn what is palliative care. So what is the aim of palliative care? That all we learn. So how will we improve the quality of life of the patient and the family? So this patient needs palliative care. So let's discuss how we will give palliative care for this patient and their family. So you can unmute yourself and talk regarding this patient's problems and how we can improve the quality of life of this patient and their family. Or you can put your
Shiva, there
suggestions.
was some chats even. Can you read it out?
Yes, yes.
There are some messages.
Yeah, you can.
I'm not getting it. Can you try it once, please? I don't see. There's a little bit of information in there.
Yeah. Are you able to see? That Swarup?
Yeah. Yeah, Shiva.
Yeah, one question I already answered. What should be we use to lubricate the
Yes, yes.
funnel? I already said silocaine jelly. And the next question is speech therapy, visual chart to communicate. Mahima said,
So that is all under the rehabilitation, right?
yes.
Goes out in that.
Then Salome said, trying to find a way to communicate with him, maybe with pictures.
Nice.
So, any other answers? Any other suggestions? If the patient is unconscious, how will you find out whether the patient is having pain or not? How will you find out? If they are not able to communicate with you verbally, how will you find it out? Any suggestions? Okay, Salome said asking closed questions with only yes or no, and let them have the thumbs up or down. by expression of their face. Monica said, by expression of their face. Then Mahima said, warning, groaning. Okay. So thank you for your contributions. So as you already mentioned, we can see their face. So when we turn when we change the positions, you can look at their face. Their face will be some kind of facial expression will be there. Otherwise, they will be producing some kind of sounds. So that time, so we have to identify. Okay, this patient is having pain. So then you can give some pain management before that, pain medications before you doing the procedures. So then the patients will get adequate pain relief. Okay. Swarup, do you need to add anything to any points you need to add?
No, sometimes even the tears also make some sense in assessing the pain. So they can't express, they don't even move their body movements even. So even sometimes you can see the grunting or the change in the facial expressions, and sometimes tears itself gives you information that the patient is suffering, maybe in that particular point of time.
Yes. Thank you. Thank you. So how will we can improve the that support the family? We understand that palliative care is a total care. So we have to look into the physical problems, psychological problems, social problems, and spiritual problems. So if the patient is having physical problems, you have to check the physical problems and assessment, do the proper assessment, and you can plan accordingly. Based on your assessment, you can that plan that treatment. No, so you have to do the proper assessment. And also you can do the that review also. So frequent review of that symptoms. You can do the frequent follow. So then only we understand. We have to know about the patient is getting adequate control of their physical symptoms. That is also very important. After controlling the physical symptoms, you can look into the psychosocial issues part also. So here, this patient is having a lot of psychosocial issues. If a patients get illness in own family, that whole family will be affecting. Okay, so so this is palliative. In palliative care, we understand that palliative care is not only for the patients; it's for the family. So here, this patient's family is also suffering. We need to give a good support to the family members too. So without family, that caregiver support or family member supports, we can't do anything. So we need them to take care of the patient. So we need to give a good support to the patients and the caregivers. So we need to understand their emotions too. So here, this is a bedbound patients. They need a lot of the patients need not lot of care. These bedbound patients, he is not able to communicate properly. That because of that he is very depressed. So lot of problems. They are not able to understand their problems properly because of loss of that communication. That unable to the communication problems also not able to speak. So this is very, very difficult. So this family is going that going on there too many problems. So what you can do is you can listen their listen their problems individually. So you can at least you can go listen that caregivers concerns. So, Sister Sini, the caregivers have any the special concerns, or do you have such conversation like that? Sister Sini, are you there?
Ma'am, can you hear me?
Yes, yes, we can hear you.
Yeah.
So can you explain about his family, that little bit about?
Yeah, actually, the family, he was the head of the family, and
Okay.
he was an extrovert person. He was a very well socially, society itself. Had a leading role.
Okay.
So all on a sudden it happened, and whole family was in fact depressed.
Okay.
They were unable to come out from that. It took almost 1 month to accept the situation.
Oh, okay.
Uh, but physiotherapy, they were then later on after discharge, physiotherapy was going on,
Mm.
but couldn't find a speech therapist. Like that, they communicated.
Okay.
So he was he is aphasic, but
Okay.
right side slowly now it is grade 1. His movement means bit he is able to move. Grade 1,
Okay.
grade 2 it seems upper limb.
Oh, okay.
But the main concern is with the communication. Again, the patient had similar episodes, but they couldn't know because he was unable to say anything. So it
Okay.
happened at night.
So,
So all
okay.
were sleeping.
Where is he right now?
Right now he is at home.
He is at home. Okay. Did he get palliative care?
No, that is another concern. He's not receiving much attention from palliative care side.
Okay. So where is he?
This is in actually he's in Kottayam.
Kottayam. Okay.
Kottayam, yeah.
Oh, okay. Yeah.
But we have contact. I gave some numbers, and now they are trying to contact.
Okay. So actually in Kerala, so each panchayat have their own palliative care settings. So each panchayat their own palliative care nurse, and secondary level palliative care nurse is also there. I think we can connect with them, and that way he can get palliative care.
Sure.
And
Sure.
also, I'll find out if there is NGO nearby in Kottayam. There, I'll connect with them also.
Okay. Okay.
Swarup, yeah, okay, thank you. Swarup, anything you want to add?
No.
Okay. So unfortunately, we don't get ostomy patients today. That is why I brought these patients for presenting today. Anyway, we have to discuss the patient problem doesn't matter. So we need to discuss any patients. So here, this patient is having a lot of problems, physical problems, and also this patient is having incontinence of urine also. Did he on Foley's catheter system?
No, now it's removed. Actually, it's removed.
Okay,
Now
come on.
he is regaining his bladder control. He is regaining means using the urinals.
Urinals. Okay, he is able to control.
He is able to control. But
Okay, that's good.
night time only they might be putting the this one diapers.
Diapers. Okay. So what about the oral
Otherwise,
intake?
it's removed. Oral intake also now it's after he is removed, he is able to take small.
Okay.
He is able to take. Yeah.
Okay.
Now the
So
main concern is this movement. He has the restriction and the communication.
okay, yeah.
He is still aphasic. We
Okay.
won't understand anything. Whatever he tries to tell a lot of things, but we won't be able to understand anything.
Oh, okay.
That is the main concern.
So
Family members also had the same concern.
okay.
Yeah.
So yeah, I think he needs continuous physiotherapy and speech therapy also. So if you don't get a physiotherapist, you can train the caregivers to give a physiotherapy.
Yeah.
For a bedbound patients, they don't know how to do the physiotherapy. So you can train the caregivers You have to tell the importance, tell the caregivers about the importance of physiotherapy, because otherwise that contracture will be there, and also muscle wasting also will be there. So that information you have to tell the caregivers. That time they will try to give some kind of physiotherapy. They, as much as possible, we can improve that we can try to that improve their muscle strength. Do the simple physiotherapy and also speech therapy also. Nowadays, the caregiver education is also important. That they will train the caregivers how to do the speech therapy and all. So that way we can. So this patient need continuous rehabilitation, as Swarup said earlier. So this patient need rehabilitation, like physical rehabilitation. Here he needs a continuous speech therapy, and physiotherapy. That way we can able to, I think we can able to improve the quality of life of these patients that way. Any other points you want to discuss? Anybody have any suggestions? Also, Sister Simi said earlier, the family members, caregivers are worried about his conditions. We have to think about their sides also. If possible, you can go and sit with them. And if you see this kind of patients, try to sit with them and listen their worries. Not only for the patients, it's for that you, if possible, you can listen that family, the caregivers worries too. So then only once they express their emotions, they will get some sort of relief. So we can't do anything out of that. At least we can able to listen their problems. Okay. So if they express their emotions, they will get some sort of relief. That is that way. If possible, if you get time, if you see this type of patients, give 5 minutes for that patients and for patient and their family, and do listen their problems. So if you don't have any questions, we can wind up. Before winding up the sessions, I'm going to show one video on colostomy care and tracheostomy. One colostomy care and another video on tracheostomy care. You can watch that video, and after that we can wind up.
No, Shiva. No.
No.
Go ahead.
Okay. So.